Well, good afternoon. It's 1:30, so we should begin. Today, I'm going to talk about the AV Wenckebach phenomenon. That all you want to know about Wenckebach phenomenon, A to Z. So about 100 years ago, when Dr. Wenckebach and Moritz were handling patients with a second-degree AV block, those whose PR interval progressively lengthened before it is blocked did very well. But those whose PR interval did not lengthen before it is blocked did very poorly. So it was a very useful information, so they called it the type 1 and type 2. They didn't know why, but it was a very useful separation. Now we know why. Type 1, it is due to reversible conditions, and the location of the block is within the AV node, and when they progress to complete AV block, junction will escape at about 40 or 50 per minute, and it's going to be transient. While in type 2, it is not due to reversible conditions, and the block is below the his bundle, that is within the ventricle, and when they progress to complete AV block, it will be the ventricle escaping at about 20 or 30 per minute, and it's going to be permanent. If it is an infarction causing this, inferior infarction will always cause a type 1, and proceptal infarction will end up with a type 2 if the patient develops a second-degree AV block, because the conduction system is caught in the process of an infarction. So this is one typical example of a AV Wenckebach phenomenon. PR interval progressively lengthens, then it's blocked. The lengthening of the PR interval is gradually decreasing. So lengthening is most between the first and second, the delta 1. And yes, PR further lengthened, but by how much? Here, it lengthened by 120 milliseconds. Here, it lengthened, but only with a 60 milliseconds. Lengthened, yes. By how much? Only by 20 milliseconds. The result of that is RR interval will get shorter and shorter. It looks a little paradoxical. When the PR is lengthening, the RR actually gets shorter and shorter because you are adding less and less amount of delta. Additionally, you cannot put 2 of this in here because this is pushed out this way. So that's the second characteristics of Wenckebach phenomenon, where the first RR is the longest, then becomes shorter and shorter until it is blocked, then of course it will be longest. And you cannot put 2 of this in here. I would call that secondary characteristics, and you wouldn't need that in AV Wenckebach phenomenon because the progressive lengthening PR interval is so obvious. So you don't need any other characteristics. But if you are dealing with the SA Wenckebach phenomenon, or junctional rhythm Wenckebach phenomenon, or atrial flutter with the Wenckebach phenomenon, then this second characteristics will become very handy. I would call that the earmark of Wenckebach phenomenon. So secondary characteristics come into play when dealing with the SA Wenckebach phenomenon, atrial flutter with the one-to-one and Wenckebach, or AV junctional rhythm with the Wenckebach phenomenon. Okay, let's see a typical example of a Wenckebach phenomenon. PR lengthens and it's blocked, and always the first RR is longer than subsequent RR. Some more examples. So first one is always longer than the next one, then of course pause. Once in a while, the last one is lengthened with more increment. outer called outlier. Many of these physiological events have an exponential curve, as you know. And the last one, so exponential curve, you have a delta here, and you have a delta here, and subsequent beats, beat 1, 2, 3, 4. So if you have if you plot the dots, you will have an exponential curve, but at the end, there may be an outlier, so it could be longer than the previous one. So that's what we are seeing here. Like this one, yes, long, little bit shorter, but last one is longer again, because the increment is suddenly increased, the outlier. This one too, long, short, but this is even longer than the first one because of this outlier. But ordinarily, if it is a truly characteristic AV Wenckebach phenomenon, it will be long RR, little bit short, then it stays about the same, then blocked. Okay, here, Wenckebach phenomenon, then conducted blocked, so 2-to-1 AV block. Should we say type 1 and type 2 back to type 1? No. If you have in a patient with, say, 2-to-1 AV block, if you have a typical Wenckebach 2-to-1 AV block, and if you have a typical Wenckebach phenomenon, you lump it all together and call it type 1. You never call type 1 and type 2 in the same patient in the same setting. When the conduction ratio is 3-to-2, short, long, blocked, short, long, blocked, the QRSs will be paired together like that. And of course, you cannot put two of this in here because this is pushed out this way. So when you have two QRSs paired together, and you cannot put two of this in here, whether you see the P or not, you can make a 3-to-2 AV Wenckebach phenomenon. Looks a little bit complicated, but at a quick glance, you might say, oh, there are P's and QRS's not paying attention to each other, complete AV block. Right away, it's not the case. Complete AV block, the escape mechanism is very regular, especially if it is a junction escaping. Junctional rhythm is the most regular rhythm of all, so the QRS is not occurring regularly, right away will rule out complete AV block. So you have to make some connection one way or another. And where you begin is after the longer RR interval, the beat that ends a longer RR interval is the first beat of a cycle. So you find this one, then try to find the P in front of it. There's a P there. This QRS is due to this P. Then what is the next P? It's there, long, longer, blocked. Short, long, longer, blocked. So even though at a quick glance you might think, oh, the P and QRS have no relationship. Oh, yes, there is a relationship. If there's no relationship, that means that this is coming from the junction. It has to occur perfectly regularly. Well, what's happening here? Yes, you see P occurring regularly, but the QRSs are not occurring regularly. 2 here, 3 here, 3 here. Then the first one is longer than next one, and you have to make a PQRS, PQRS. There's a slowed downstroke. There's a P hidden there. So regularly occurring P with the AV Wenckebach phenomenon. You can time it with your caliper, and it will time right here on the slowed downstroke. It will time right here where the slowed upstroke is there. So P is there, P is there. Patient with the inferior wall STEMI now went into second degree AV block, always type 2. PR like that, PR long, PR longer. Then P here is that's blocked. cycle begins here. PR short, PR long. P is hidden within the QRS, and it's conducting to this QRS, and the P is here, and that's the one that's blocked. We have a 3-channel rhythm strip. Useless, but this is useful. So don't waste time with the useless leads, but go find which lead is most useful, then spend the time on it. Not on this one, not on this one. You don't make anything out of it. You don't make anything out of it. But here you see the P clearly. Isn't it amazing? Certain leads are so useful, other leads are useless. And PR short, long, longer, typical Wenckebach phenomenon. What is the P? Well, you have to take out your caliper and march it out. It's there. What is the next one? It will time on top of the T, and it will time on top of the T. And it's the P here that's blocked, and next cycle begins. Well, unusual, 2 together, 3 together, 2 together, 2 together. Then becomes regular. Is this sinus bradycardia? No. P's are occurring regularly, short, long, blocked, short. Well, there must be P hidden somewhere there. You have to find out from the caliper. Okay, here, must be somewhere hidden here. And that's the one that's blocked. Then new cycle begins, a short, long, longer, blocked. 3 to 2, 4 to 3, 3 to 2, 3 to 2. Then progress to what? 2 to 1 AV block. Conducted blocked, conducted blocked. Shall we say type 1, type 2? No, it is a type 1 all the way. Consider that the conduction ratio is, say, 4 to 3. Then 3 to 2, what comes next? 2 to 1. So 2 to 1 can be the shortest AV Wenckebach cycle. So this is type 1 all the way. You shouldn't call type 1, and type 2. In a given patient, in a given situation, they don't have a type 1 and type 2 at the same time. Wenckebach phenomenon, 2 to 1, 2 to 1, Wenckebach. Shall we say type 1, type 2, type 1? No, it is a type 1 all the way. So 3 to 2 becomes a 2 to 1, 2 to 1, back to 3 to 2. 2 to 1, mostly 2 to 1, but at least one time there was an AV Wenckebach phenomenon, so you call whole thing as a type 1, not type 2, type 1, type 2, no, type 1. So 3 to 2 next becomes a 2 to 1. So 2 to 1 can be blocked above the, within the AV junction, there is a type 1, or it could be below the his bundle. So how do we tell? What are the earmarks of a block within the AV node and below the his bundle? There is a type 1 and type 2. In type 1, 2 to 1 AV block, the PR tends to be longer than normal, and QRSs are narrow. And when you see this, somewhere along the way, there will be typical AV Wenckebach phenomenon. So this is a type 1 AV block, that is a block within the AV node due to reversible conditions. In 2 to 1 AV block, if the PR is not long and QRS is wide, most likely it's a block below the his bundle. You will not see Wenckebach phenomenon in other places. This is a block below the his bundle. PQRS, PQRS, P doesn't lengthen, then what is the P? This is a T, judging from this. So there's no P. Timing-wise, next P should have occurred here. There's no P. So what are we dealing with? Then later, the same patient became regular. When it becomes regular, I lined up this with this one. Which one lines up with this one? It's this one. We are dealing with AV Wenckebach phenomenon from the sinus node to the atrium. So SA322 SA block, not AV block. And that's why you are able to line up this with this one and so on. So there's no blocked P, but unusual for QRS to be paired like that. Should we say atrial bigeminy? No, P waves are identical looking, yet there's no P block. So this is a typical SA322 SA Wenckebach phenomenon. And of course, you won't be able to put two of these in here, and you have to meet that criteria. Well, what is the P? There's no blocked P though. This is a T. This is a T. Well, judging from what happened the next moment, this lines up and this lines up with this. So this is a 1-to-1 conduction, 3-to-2 SA block. Sinus node dysfunction, yeah. So it can be diagrammed like that. Ladder diagram, you can have as many ladder as you need. Ordinarily, we just have A, V, V. But here, I have the level of a sinus node, SA junction, then atrium, AV junction, and ventricle. So sinus node is firing regularly at that rate, which is what's happening here. Went to the atrium promptly, to the ventricle, went to the atrium okay, but with a delay, then eventually went to the ventricle. Sinus node fired somewhere here, but didn't get to the atrium, so no P. Promptly, delay, no P. Promptly, delay, no P. How about this one? Two together, then the two together, then long like that. There's no P that's blocked. Again, we're seeing SA block. But PR is a little bit lengthening. So this is a dual level Wenckebach phenomenon. Let's see whether I have a diagram. Okay, sinus node is firing here. Sinus node fired here. Took a little longer time to get to the atrium. Then also PR is lengthening. So there's a Wenckebach phenomenon between sinus node and atrium and within the AV node. So dual level AV Wenckebach phenomenon. Okay, again, I need a ladder in the sinus node. So sinus node fired regularly, promptly to atrium, then to the ventricle, delayed to atrium, but not only that, PR also lengthens. So this is dual level Wenckebach phenomenon. Wenckebach between the sinus node and atrium, also Wenckebach within the AV junction. PR short, PR long, nothing. PR short, PR long, nothing. So sinus node dysfunction as well as AV conduction problem. So PR like that, PR long, PR longer, but there's no blocked P. This could be another example of a SA Wenckebach phenomenon combined with AV Wenckebach phenomenon. So dual level AV Wenckebach, dual level Wenckebach phenomenon. interesting, very regular rhythm. All of a sudden, pause, pause, pause. What is this pause made of? It's exactly 2 basic cycle length. Unfortunately, we don't have a caliper, but let's try this. It's exactly 2 basic cycle length. What does that tell me? Sinus node is firing, but didn't get to the atrium, so no P, no QRS. Sinus node is firing, but didn't get to the atrium, so no P, no QRS. But this interval is exactly 2 basic cycle length. So this is a type 2 SA block. If it is a type 1, you won't be able to put 2 of this in here. So that's the clue. If you are able to put 2 of this in here, that's a type 2. If you are not able to put 2 of this in here, then that means that this is pushed out this way. That means this is a type 1. Another interesting situation, perfectly regular sinus rhythm. Then pause, pause, pause. You try to make, what is this pause made of? Can you put 2 of this in here? Yes. So another example of a type 2 SA block. Okay, patient is in atrial fib. You rate controlled, then rate became slow with the digitalis. Then later, it became like that and still irregularly irregular. So lot of atrial activities are blocked, only some are conducted. Then later, the patient's QRS all of a sudden became perfectly regular. So what's happening? None of the atrial impulse is getting to the AV junction, and patient is now living on junctional escape mechanism. From the AV junction standpoint, no impulse is getting to it. So you call it entrance block. So if you look at it from AV junctional standpoint, no impulse is getting into it. So complete entrance block, and patient is not dying because there's a escape mechanism. The junction, the natural demand pacemaker is escaping. So if you are treating a patient with the atrial fib and rapid ventricular response, you want to control the ventricular rate with the digitalis, and you controlled it, and eventually, if you give it too much, you can have a complete entrance block, and patient is living on junctional escape. Rather far advanced state of digitalis intoxication. No, it's the atrial fib because there's no flutter waves. You might call fib flutter, but it is not the atrial active, or if it is a flutter, it is not flutter conducting to say 10-to-1 or 8-to-1 conduction. If so, what appears to be flutter and the QRS should maintain fixed relationship. They don't. So it is not atrial flutter with a fixed slow conduction ratio, but just the atrial fib continuing and complete entrance block and junction escaping, and rather serious situation now. And what comes next? Then that junctional escape, instead of just escaping, it will be accelerated. So that's the next step. So again, patient is in atrial fib in the atrium, but the QRS is regular. That means a junctional rhythm. Then this is what's happening. Several beats grouped together. And the first one is always longer than others. then you cannot put two of this in here. Remember, that's the secondary characteristics or earmarks of a Wenckebach phenomenon. So this is a junctional tachycardia with a what we call exit block. So instead of an entrance block, which is impulse of failing to get into the junction, now impulse has a difficulty getting out of the junction and manifesting as a Wenckebach phenomenon. So junctional pacemaker fired here promptly, junctional pacemaker fired somewhere here, delayed, junctional pacemaker fired here, further delay, further delay, further delay, then block. So this is an exit block with a junctional tachycardia, rather far advanced state of digitalis intoxication. And further clue is QRSs are paired together. This is all junctional rhythm, but paired together. What does it mean? Junction promptly, junction delay, junction blocked. Junction promptly, junction delay, junction blocked. So that's what we are seeing. It can be diagrammed like that. Junctional pacemaker is accelerated and firing at about 150 per minute. And promptly delay, further delay, further delay, further delay, blocked. Promptly delay, further delay, blocked. Here, it's a 2-to-1, junctional tachycardia with a 2-to-1 AV conduction. Junctional tachycardia with a 3-to-2, 4-to-3, 3-to-2. So exit block, far advanced state of digitalis intoxication. If we did not recognize this and continue to give digitalis, patient would die in digitoxicity. Okay, here's a patient with a perfectly regular rhythm, very fast. Then moment later, there's a group beating. Now 6 together, 4 together, 3 together, 4 together. Okay, is the first one a little bit longer than next one? Yes, first one is a little bit longer than next one. Can you put two of these in here? No. There's a good earmarks of AV Wenckebach phenomenon. So this is a patient in atrial flutter. You slow down the flutter rate with the antiarrhythmics will easily slow down flutter rate from 300 to 200 or to 250 or 200 or even 180. And AV node, which was not able to conduct a 1-to-1 at 300 per minute, now is able to conduct a 1-to-1 at say 220 or 200 per minute. And it is doing it 1-to-1, but eventually the AV conduction system poops out, and it can do for, say, 7 beats, then couldn't do it anymore. It can do it for 6 beats, but couldn't do it anymore. It could do for 4 beats and couldn't do it anymore. And it's manifesting as a Wenckebach phenomenon, and we can call Wenckebach phenomenon because of the two earmarks. That is, among the group beating, the first one is always slightly longer than this, and you cannot put two of this in here. Good earmarks of Wenckebach phenomenon. And later, with the, later it became like that. In V1, you can see that atrial activities here. Promptly delay blocked, promptly delay blocked, promptly blocked, promptly delay blocked. Then with the carotid sinus massage, you can make it 2-to-1. Then what do you see? Atrial, 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 atrial. So that's V1, but in the inferior leads, during the long pause, you typically see good flutter wave. Of course, you have to be able to recognize this as a flutter wave. If you don't, you will never make atrial flutter. So this is a good atrial flutter. Sloping up, slanting down, then dips, sloping up, slanting down, then dip. If you don't recognize this as a flutter wave, you will never call this a flutter wave. That is you have to recognize me. Then you can say, oh, that's Dr. Wang walking down there. If you don't recognize me, you never can call, oh, that's Dr. Wang. You know what I mean? So how many of you are comfortable in calling, oh, that's a typical flutter wave, rather than one inverted P next to inverted P? No. Slanting up, sloping up, slanting down, dipping, sloping up, slanting down. Well, unfortunately, the QRS is interrupting it. But only one beat is plenty for me to say that, oh, this is atrial flutter. And the distance, okay, here's another one. Sloping up, slanting down, dipping. There may be another one. Well, two at least here and here.
Only one lead, Dr. Wang, the flutter, because if I just looked at V1,
well, flutter wave is best seen in the inferior lead, so I put which lead it is. It's in lead 2. That's where you see the flutter wave best. So are you all comfortable in calling this? Oh yeah, I see it, flutter wave. What do you think? Jessica, are you comfortable in calling it flutter wave? When I walk down the hallway, I know you will call me, oh, there goes Dr. Wang. So you can say, oh, there's an atrial flutter here. Yeah, it is an atrial flutter. Whenever anything like looking like that, so slow, slanting down, why not could this be just the inverted P, inverted P, inverted P, inverted P? Well, then this will not slant down. It will be horizontal. It will be straight, not slanting down. Yeah, you can look at it a little while and become familiar with it. In atrial flutter, sometimes the P is not conducted to next one, but conducted to one after that. You might say, gee, how can a P jump over QRS and conduct to next one? Well, it is not jumping over anything. If you look at the diagram, it's not jumping over anything. It's just going where it should go. One analogy could be, say, a city bus dispatcher. Does he have to wait for the bus in front to reach the terminal before he sends the next one? No. While the bus is on its way to the terminal station, he can dispatch a bus. And that's what we are seeing. So this P is not conducted to this one. Yes, this impulse is going down this way. While it is on its way to the terminal station, the impulse can begin here, now going to the ventricle. And it's this P that's blocked. And it's this P, this is not the blocked P, this is the one that's conducting to next one. So in atrial AV Wenckebach phenomenon, keep in mind that sometimes the P can be conducted not to the next one, but it can be conducted to the one after that.
So like, if you look at the one that you said, I'm confused because this one, usually this one's connected to this one.
Yeah.
But then with this one and
Yeah.
I'm kind of confused. So this one's connected by which one then? Oh, sorry.
Okay. The way to visualize this is, it is not complete AV block. First of all, P's are occurring regularly, and there's a group beating. So you have to make, oh, I'm dealing with the Wenckebach phenomenon. In Wenckebach phenomenon, which is the first beat of the cycle after the longest pause. So this is the first beat of a cycle. Then, okay, this is the first bit. What is the P? You look for P in front of it, it's there. So it's that P, it's this P conducting to that one. And let's try again here. Okay, what is the long interval, long RR interval? So this is the first beat of the cycle. Then you look for P. What is the P? P should be in front of it. It's not there, it's not there. And, oh, it's there. It's long? Well, yes. There's no other way to draw this diagram. So sometimes a P can be conducted not to the next one, but one after that. Are you comfortable with this situation? What? This P not conducting to that one, but conducting to this one? And this is from that P? Yes, that's what it is. Some more example. So this P not to this QRS, but this P is to that one. Again, see which one has the longest RR interval? This one. So this has to be the first beat of the next cycle. Then, okay, what is the P causing this one? You look in front, it's not there, not there, not there. Ah, it's there. So you draw it like that. So so this P is conducting not to last one, but to this one. This P not to this one, but to next one. Again, think of this city bus dispatcher. Are you comfortable with it? Some more example of the same thing. This P not to that QRS, but to this one. So how do I know which is the first beat of the cycle? Well, find the long RR interval. That's the first, long RR interval. That's the first beat of the next cycle. And there has to be a P in front of it. It's not there, not there, not there. Finally, it's here. Ah, that P is conducting to that one.
So your suspicion happens when the first beat of the new cycle is very prolonged.
Yeah, the even first one, ordinarily the first beat of a cycle has a normal PR interval, but it can be this long. This patient has a frequent PVCs. Among the conducted sinus beats, PR short, PR long, PR longer, then P block. Very interesting situation. Patient has a ventricular bigeminy, and among the sinus beats, they have a Wenckebach phenomenon. What's causing it? Well, PVC conducts retrogradely, penetrating into AV junction, disturbing the AV junctional tissue so that next impulse will take a longer time. It has a further penetration, next beat takes even longer time. It had a further penetration, next beat is just not able to conduct. So during ventricular bigeminy, among the sinus beats, there could be Wenckebach phenomenon. But this is not primary conduction problem. This is a retrograde conduction from the PVC, rendering the AV junction progressively more and more refractory, so that the next beat is conducting with a longer PR interval, then eventually blocked. So nobody should think, oh, this patient has a second-degree AV block. No, it's the trick the PVC is playing. This patient has nothing wrong whatsoever in the AV conduction system. So patient has a 2-to-1 AV block, conducted blocked, conducted blocked, conducted blocked. But among those conducted beats, there's a Wenckebach phenomenon. So you can have two kinds of a block, 2-to-1, while among the conducted beats, there's a Wenckebach phenomenon. Interesting situation.
What do you call that then? Is that like?
Well, second degree AV block, period, yeah. Of a type 1, of course, yeah. That is a block within the AV junction due to reversible conditions. Most likely, this patient will not end up getting a pacemaker. So we've been talking about anterograde Wenckebach phenomenon, but there could be a retrograde VA Wenckebach phenomenon. This is a ventricular tachycardia. Then blip, nothing, blip, nothing, blip, nothing. What are we seeing? So ventricular tachycardia focuses firing at that rate, went to the ventricle, of course, each time, but goes all the way to the atrium, then blocked, all the way to atrium, blocked. So 2-to-1 retrograde VA conduction. What's happening here? Ventricular tachycardia, blip, blip, nothing, blip, blip, nothing. Not only that, but the QRS to blip short, QRS to blip long, nothing. So this is a 3-to-2 retrograde VA Wenckebach phenomenon. Promptly delay blocked, promptly delay blocked. How about this one? 5-to-4 retrograde VA Wenckebach phenomenon. So ventricle is under the control of a VTAC focus. So it's occurring regularly, but retrograde, retrograde, retrograde. See, it's falling gradually behind and behind, then nothing. Retrograde, 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 falling gradually further behind, then nothing. So 5-to-4 retrograde VA Wenckebach phenomenon. Here, PR is, instead of getting stable or staying stable or getting progressively longer, progressively shorter, 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 then becomes normal. What are we seeing? This PVC went to atrium all the way, then turned around, went to the ventricle. Then it turned around and trying to go back to the atrium, but it is blocked. However, it disturbed the AV conduction system, enough, so that the next P is going to take a longer time to go to the ventricle. The effect is still lingering on, but less and less disturbed, so that PR will get shorter, 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 and becomes normal. And you might call this a reverse Wenckebach phenomenon. PR, instead of lengthening, PR is shortening among the sinus beats. So now we heard the anterograde Wenckebach phenomenon, retrograde Wenckebach phenomenon. This is a reverse Wenckebach phenomenon.
What would cause that PVC to cause the echo beat to go down to the V again?
Well, this patient must have a dual AV conduction system. So this patient is set up for AV and RT. And without that, it won't come back this way. So this is an echo beat. Then now try to go back to atrium. It didn't make it, but it disturbed the AV junction enough so that when the next P is going to conduct, it's going to conduct with a longer PR interval. The effect is lingering on, but less and less. So PR will become gradually normal, gradually shorter and shorter until it becomes normal. So you have seen everything about Wenckebach phenomenon. Wenckebach phenomenon can occur anywhere along the conduction system. SA junction, Of course, this is the initial description of a Wenckebach phenomenon in AV junction, or it can occur within the His bundle with the between the proximal and distal His, or it can occur below the His bundle, or it can occur in the right bundle branch, left bundle branch, or within the Purkinje system. Okay, this is typical AV Wenckebach phenomenon. AH gets longer and longer while HV stays the same. And that's a typical AV Wenckebach phenomenon. What's happening here? There's a Wenckebach phenomenon between proximal and distal His. AH stays the same, H prime V stays the same. What's lengthening is between H and H prime. So this is a Wenckebach phenomenon within the His bundle. These authors claim that normal conduction, slightly right bundle, little more right bundle, complete right bundle branch block. And they are claiming that this is Wenckebach phenomenon within the right bundle branch. Normal, slightly more complete right bundle branch block. Same authors are claiming that normal, slightly left bundle, slightly more complete left bundle branch block. So they are claiming that this is how many ratio? 3 to 2? No. Yeah. So yeah, 5 to 4 Wenckebach phenomenon within the left bundle branch block. I have never seen this personally, so it must be very, very rare. But since I said A to Z, I have to say everything about Wenckebach phenomenon. Are you comfortable with this? Both that and this one. It makes sense. Normal, slightly right, more right bundle branch block, complete right bundle branch block. Okay, this patient is being paced, but pacemaker to QRS is short, longer, then eventually pacemaker fails to pace the ventricle. I will claim that this is a Wenckebach phenomenon within the Purkinje fiber. So you have seen Wenckebach phenomenon in SA junction, AV junction, within the His, below the His, and within the right bundle branch, within the left bundle branch, and in the Purkinje fiber. Interesting patient, sinus rhythm, all of a sudden, PR lengthens. Next moment, PR short, long, blocked, typical Wenckebach phenomenon. Next moment, PR doesn't change, but all of a sudden, the regularly occurring P is blocked, typical type 2 second degree AV block. I mentioned that in a given patient, in a given setting, they don't have a type 1 and type 2 at the same time. So what's happening? First degree, unexpectedly, then type 1 and type 2, something is a fish. So what's happening is revealed by this one, junctional premature beat. We know that junctional premature beat can play all kinds of tricks. So there was a junctional premature beat. Which did not manifest into the ventricle or to the atrium. So from the surface ECG, you don't see the existence of a junctional premature beat. We call it completely hidden from the surface ECG. And they use the term concealed. So concealed junctional premature beat is affecting the AV junction in such a way that when next P is going to conduct, it's going to take longer than usual time. So concealed junctional premature beat affecting subsequent beat, causing PR to be transiently lengthened. Same junctional premature beat. Didn't get to the ventricle, didn't get to the atrium. So from the surface ECG, you don't see the existence of a junctional premature beat. It occurred, but we don't see it. It's completely hidden. So completely concealed junctional premature beat, making the conduction system refractory so that when the next P is going to conduct, it cannot do it. So you have a conducted, blocked, conducted, blocked. If you have this and this in sequence, so long, so first degree, then this one, then it sure will look like AV Wenckebach phenomenon. So this is a concealed junctional premature beat playing a trick, causing transient, unexpected PR prolongation, or what appears to be Wenckebach phenomenon, or what appears to be type 2 second-degree AV block. And when I diagrammed it like that, nobody's going to buy it. You can say all you want, but I'm not going to buy it. So I had to have an EP person to do EP study. And indeed, when the PR lengthened, there was a junctional premature beat. When there was a junctional premature beat, it will affect the subsequent beat to conduct with a longer PR interval. Here, junctional premature beat occurred, but we don't see it on the surface ECG because it's completely hidden or concealed, affecting next beat to occur with a longer PR interval. Then junctional premature beat occurred, but again completely hidden, but affecting next beat, next P to be blocked. So it looks like a Wenckebach phenomenon, but it is a junctional premature beat playing a trick. Here, junctional premature beat next to P is blocked. Junctional premature beat next to beat is blocked. Looks like a type 2 second-degree AV block. So I will call this a pseudo-AV Wenckebach phenomenon. Now, you truly heard the A to Z of a Wenckebach phenomenon, including pseudo-AV Wenckebach phenomenon.
Do you know anything about the history of that person? Why would they have?
So primary problem is what? Junctional premature beat.
What would cause that?
Well, just like what causes a PVCs, what causes a PACs. So it's what causes a junctional premature beat? Irritable ventricle, I suppose. So if you ask me, well, what causes a PACs? What causes a PVCs? Same question. What causes a PJCs? The same answer will be applied to there too. Okay, question to you. Is this a P with a first degree AV block? Or is this a U of the preceding cycle? Or is this P and U together? Answer the question. Jeremy, what do you think? P alone or U alone or P and U together? Make good use of PVCs. During the compensatory pause, there could be very, very useful information. So make a good use of PVCs, which this patient had here, PVC, PVC. What do you see during the compensatory pause? So what are you going to call this one? It's too far out from this QRS, so it has nothing to do with this. If it is a U, it has to be related to a previous cycle, but it has nothing to do with this. So what is this? It has to be a U. I mean the P, P. But this is a little bulkier than this one. This is a little bit bulkier than this one. Is there U added on top of it? You only can speculate, but you cannot be certain. Now you need help from the patient. What are you going to make out of it? Look at V3. Where is that P? P is not there. So this patient is a very kind person. And knowing that we are struggling, okay, I'm going to help you. I'm going to help you, Jeremy. I'm going to help you by making my P wave in V3 isoelectric. I don't know how she could do that, but she did it. Then what's this one? V3 is from here to here. So she made the P isoelectric. So P should never show up. Then what's this one then? It has to be a U. So it is a summation of a P and U. So many times the compensatory pause after the PVC can be very useful. So make a good use of it. You might say, oh, who cares? Oh yeah, it's very important. If this is a patient that you are treating for infective endocarditis of the aortic valve, until yesterday, PR was normal, but today PR is long. That could be the first or the only sign of paravalvular abscess. The patient may not feel any different, but this could be the first sign or only sign of paravalvular abscess, which is a surgical entity. If this is a patient that you are treating with a digitalis, PR was normal until yesterday, now it's long, that could be the beginning of digitoxicity. If this is a young person who enjoys camping and came to you with a knee joint pain, and that could be the sign of Lyme carditis. Well, if you are seeing this patient for pre-op consultation, and this prominent U is due to hypokalemia, and you didn't do anything about it, during the induction of anesthesia, during the next day, the patient can rest on the operating table and could not be resuscitated. The case is audited, and you saw the patient on pre-op consultation the night before. This ECG was available, prominent U was there, but you didn't do anything about it. Well, you are not going to look good. If it is a U only, without a P, that means this is an accelerated junctional rhythm. What's the clinical significance of accelerated junctional rhythm? Digitalis intoxication or excess amount of catecholamines circulating, which means any stressful condition. So it's very important to be able to find out whether it's a P alone or U alone or a summation of a P and U, because it has a good clinical relevance. Thank you for your attention.